Okay, we are asking.
To yourself like this, whatever is being challenged for you. So, because they are challenged, that's why that the question is done. So,
Senanga HNP, can you hear us? Are you with us? Senanga.
Yes, we can hear you.
Okay. Are you with Movita?
Yes. Okay.
Okay. So we'll project the case from here, and then you take us through it. Is that okay?
That's okay.
All right. Thank you very much. You can mute. Nyambe, are you able to get us?
Yes, sir.
All right. Thank you. Arthur Davison, are we being heard?
They're supposed to unmute themselves so that we
Arthur Davison.
I think even someone from my side is next to them. You're on mute.
Arthur Davison, can you hear us? No, you're on mute.
Yeah, they're saying the hub is on mute.
No, the hub is not on mute. We can hear you. Can you hear us? Okay. AIDC, are you able to get us clearly?
Yes, we are able to get you clearly, Dr. Mpeta.
Thank you very much. Chipata Central.
Just wait, otherwise we are muted.
Okay, don't worry. Namseche. Namseche.
We're unmuted. We can get you.
All right, thank you very much. You can now mute yourself.
That means they're able to get us. Hey.
Lundazi. Yes.
Yes. We can hear you. We can hear you.
Thank you. You can mute yourself. Then look, HNP.
Good afternoon.
Good afternoon. Thank you very much. We can hear you.
We can hear you loud and clear.
College of Nursing. Your camera is blurred. Mansa? You can hear us, but we can't see you because there's something there.
We just want to speak.
Hello.
Hello. Good afternoon.
Good afternoon. Thank you. Can you hear us?
Yes, we can hear you clearly.
All right. Thank you.
Hello.
Onze, can you hear us?
Hello.
Should control. But I think he after it's still undated.
We are kindly mute yourselves. We are ready to start.
But not
Not muted.
I was hoping I get the call, but see, Mr. Stinger.
The one who is talking to Mr. Stinga, kindly mute yourself.
Sorry.
Please mute yourselves. These two are not muted. I don't know how to mute them. There, these two are not muted. I don't know how to mute them. There. So good afternoon, everyone, and welcome to the third session of the Ministry of Health HIV/TB Tele-Echo. And today we'll be discussing something very interesting, and we've actually been joined by the Zambia Field Epidemiology Program, and it will be talking about what they are doing, the training, and the works they've been doing with regards to HIV. I've got quite a powerful panel today, which will be discussing this from the Field Epidemiological Program. And we have been joined by a number of experts. I think I will introduce them before they start from the Field Epidemiological Program. And then within the hub, we've got HNP students, we've got various infectious disease specialists who are located at various points and the registrars as well. We will start by having a recap of last week's topic, which was cryptococcal meningitis screening, and it will be presented by Mrs. McQuanGOLE.
Last week's echo session was on cryptococcal meningitis screening. We discussed that cryptococcal antigen screening and preemptive treatment is very important because it reduces mortality by preventing cryptococcal meningitis. Therefore, Zambia recommends screening all people living with HIV with a CD4 less than 100 and those clans who are in stages 3 to 4 of illness. It was emphasized that
patients with cryptococcal meningitis should receive immediate treatment with amphotericin B and plicitocin, and that ART should be delayed in patients with cryptococcal meningitis or cryptococcal antigenemia to prevent iris. Thank you.
Thank you very much, Mrs. Makupe, for that recap. So we will definitely going straight into the didactic presentation. And to begin with, we shall invite Dr. Nyambe Sinyange, who will talk about the program briefly.
Good afternoon. So my name is Dr. Nyambe Sinyange. And, I will be presenting on an overview of the Zambia Field Epidemiology Training Program. This is going to set the pace of why Dr. MUKWANGOLE is going to talk about the investigation for HIV RASH. So Field Epidemiology Training Program. So in epidemiology, our definition, which will stand the test of times, is the study of disease in terms of person, place, and time. But more importantly, is to use such studies in applying to the control of public health problems. So what makes the Field Epidemiology Training Program different from other epidemiology training programs? So this training is basically hands-on. You learn by doing. You are in class only for 25% of the time, where you are given your necessary epidemiological skills. So you learn all your research methods during that 25%, and the remaining 75%, you apply what you've learned to control public health problems. So those skills now enable you to conduct public health surveillance. Those skills enable you to conduct outbreak investigations. But we don't want to end there. We also want those skills to help you in communicating your findings. So we also want a lot of publications as some of our outputs. So in Zambia, we have a two-tiered approach. In many countries, you may see a three-tiered approach, frontline, intermediate, and advanced. So in Zambia, we only have two tiers. The frontline, where we target the district and partly provincial staff, and then the advanced, where we target people at national level and also partly province. Basically training public health leaders. So the program started in 2014 and is currently housed at the Zambia National Public Health Institute. So far, we've graduated 2 cohorts of the advanced and 4 cohorts of the frontline. Right. So key, as some of our key outputs is that FETP, which is learning by doing, they spend 75% of their work in the field. To make a difference in surveillance, we need quick detection and quick response. So our FETP residents are among the responders for public health emergencies. So most of the time, when you hear of outbreaks, they are among the frontline health workers in the response. But they don't only end with outbreaks, they also help in surveillance system evaluations or data quality assessments of surveillance systems. And also they learn detailed or advanced epidemiological analysis, which we work hand in hand with universities, University of Zambia, Levi, Manawasa medical universities, to make sure that we give them the necessary advanced epidemiological skills. And to strengthen or to make sure they are comfortable with scientific communication, we make sure that part of the deliverables include them making presentations, either oral or poster, at international conferences. And we're also training them as future mentors of the program. So they participate a lot in capacity building trainings. Next slide. So this is an MOH program, government owned, and we have received a lot of support from our partners, especially CDC, who have been the pioneers from the beginning. We've also worked hand in hand with the University of Zambia, so that 2-year program is equivalent to a Master's of Science. At the end of the 2 years, you get your Master's. We've also worked with Public Health England, World Health Organization, and the World Bank. So World Health Organization has really helped us in training the frontline residents. Next slide. So just to give you a snapshot of some of the analytical projects that our residents are doing, you can see we are doing a lot of HIV-related work. But with some of the new developments like HIV recency testing, we want our residents to move in and also be able to detect new cases and also try to investigate those as clusters of outbreaks using the epidemiological skills that they learn in class. Next slide. So how do you get to link up with us? So whenever you suspect an outbreak or hear about any outbreak, you can contact us. Those are my contact details and my email address. You can also contact Dr. Jonas Hines from CDC. That's his email and phone number. So we're going to have a new cohort starting this year around October. 10 positions are available. So those that have interest in knowing about diseases, not just as individual cases, but knowing the disease in terms of person, place, and time, and using that to control public health problems, having hands-on experience, you're welcome to apply. And please let others know who are interested. We want to develop and train a big pool of public health leaders, a big pool of disease detectives, so that we are able to detect quickly, respond better, and have good surveillance systems. So thank you very much. I will now hand over to Dr. Chika, who is going to give us an example of what they do in the field using the epidemiological research methods that they learn. Dr. Chika, please.
Thank you. You want to take it up? Okay. Okay, good afternoon once again. My name is Dr. CHIKAMA MUKWANGOLE, as earlier introduced, and I am here to present to you the RASH clusters among people living with HIV in Zambia, an investigation that we are still doing. So the learning objectives include the fact that we are here to present the preliminary findings from an investigation of rashes among people living with HIV in Zambia. And we are here to discuss the differential diagnosis for the rashes being reported in people living with HIV. The investigation came about as a result of the call which was made at this platform in a session which was presented on the 30th of October, 2019, where a 35-year-old woman living with HIV developed an exfoliative rash affecting the periorbital area, the neck, and both elbows. And this rash was attributed to DTG, which she had recently been switched to. There was no history of taking IPT or any sulfur-containing drugs.
Okay, so thank you very much. And I think most of us are very familiar with some of the cases we have presented over DTG. So we'll now go straight into the 4 questions, and we'll have a minute for each 4 questions. So kindly make sure that you are ready for them. So the first 4 question is, which of the following is commonly associated with side effects of dolutegravir? A, metallic taste in the mouth. B, depression. C, hyperglycemia. D, rash. So which of the following is associated with side effects of dolutegravir? A, metallic taste. B, depression. C, hyperglycemia. D, rash. So you can go ahead and pour We have got exactly 60 seconds from now. So we still have a few trying to vote, and we can go to the second poll question now. And the second poll question is, RASH is a side effect of isoniazid therapy. Is it true or false? So we've got, again, 30 seconds for this poll. Okay, let's go to the third poll question. And I want you guys to actually look at the pictures. So which of the following depicts the classic rash associated with pellagra? Is it A? Is it B? Is it C? Is it D? So please make sure that you see those pictures carefully and which rash is typically associated with pellagra. We have got six. Okay. 60 seconds from now. This should be easy, isn't it? So we expect a number of people. We still have a number of people in the network who haven't voted. Okay, thank you very much. We'll now go to the last poll question, which is which of the following is the classic symptom of pellagra? Which of the following is the classic symptom of pellagra? A, difficult breathing, B, depression, C, dyspepsia, D, diarrhea. Which of the following is a classic symptom of pellagra? Difficult breathing, depression, dyspepsia, and diarrhea. We've got another minute starting from now. We still have a number about only 70% have voted of the total participants. We've got 10 more seconds. I can't see people from Kanyama. I can see people from Kanyama haven't voted. They are only on their phones.
We had a diagnosis that she had tumor on the spleen or in the spleen. She might not.
Okay, so I was talking about some common HIV medicines which are culprits in causing skin conditions in people living with HIV. These include ARVs, anti-tuberculous treatments, as well as sulfur-containing drugs like Septrin. Now, photosensitivity rashes occur in approximately 5% of people living with HIV, and HIV itself can induce photosensitivity. Other causes include other drugs and conditions like pellagra and porphyria. Okay, DTG itself is not classically associated with rash, but hypersensitivity reactions occur in less than 1% of the patients taking the drug, and pruritus in about approximately 2%, but commonly associated with other side effects such as hyperglycemia or abnormal liver function tests. DTG has not necessarily been associated with pellagra. Okay. So in trying to investigate these rashes among people living with HIV, we set out objectives. And the first one was to find additional cases of rash among people living with HIV and better characterize the clinical syndrome, and also to identify potential causes of rashes being reported among people living with HIV in Zambia. So we set out the methods that we used to investigate. We divided them into two. That was phase one. In phase one, this was running from November to December 2019. And in this phase, we requested for information from clinicians via an online questionnaire. And we, following the echo session that brought to the attention that there are rashes being reported, we advertised the same questionnaire so that people could give us some information. And we followed up any leads that could give us more information concerning rashes and people living with HIV. And with phase two, which is ongoing, we are now collecting patient-level data using a RASH case report form, which we have distributed. And we're also reviewing photos of patients in consultation with the dermatologists. And where feasible, we'll begin collecting additional samples or information so that we better diagnose the cases that we're seeing. So for the results for phase one, 17 sites reported seeing rashes in Zambia, and these came from Eastern, Southern, Western, and Lusaka provinces. This represented well over 40 patients that had some rashes. So the conditions being suspected out there by the clinicians who sent us the information were pellagra was suspected from 7 sites. Hypersensitivity reactions were suspected from 4 sites. Others reported scabies, but several of them never indicated what sort of rashes they were seeing. We availed the pictures which came from 8 sites to the dermatologists, And in his review, he thought that pellagra was in 4 or 5 pictures that he reviewed. Photoallergic drug eruptions were 2 to 3, but most of the pictures, other pictures that we had out of the 15, diagnosis was not easy to make. Those are some of the pictures that we got from around the country. Okay, I hope they are clear. So some of the limitations that we had with our phase 1 process was that the information that we were supplied with from the clinicians, the forms were not completely filled in, so there were quite a few gaps, which made it a bit difficult in some instances to make sense out of what we were receiving. And the quality of the photographs was a bit hard. Of course, this we're not blaming anyone, but probably we can aim better next time. And at this stage, we never collected any samples from our patients. And the echo session raised alarm about the DTG, and this may potentially have led to a correlation bias. Now, given that the clinicians, most of them are seeing or reporting pellagra in people living with HIV, we thought probably we could just highlight a few points on pellagra, which is basically a niacin or vitamin B3 deficiency. It's characterized by the so-called 4Ds, and these include dermatitis or rash, diarrhea, dementia, and death. Now, when you talk about the rash, it classically presents in a symmetrical way in sun-exposed areas, including the neck, like you can see in the picture next. And it usually presents in a hyperkeratotic manner, or indeed, it's a rough patch of skin that you develop. The causes mostly are low dietary intake of niacin and or tryptophan, which is a precursor for niacin, or impaired endogenous niacin synthesis. It's more common in people who live, among people living with HIV, and treatment is usually simple by way of giving multivitamins with nicotinamide. Now, there was an investigation in Malawi, 2017, where they had upscaled their IPT program successfully, but unfortunately, cases of pellagra started showing up, and the hypothesis of what the mechanism was in terms of why they were having these cases was twofold, where it was low dietary intake, one, because of the type of diet that we have in the sub-Saharan, which is made, or should we simply say climate change effects. And then there was impaired endogenous synthesis, which can come about as a result of chronic inflammation due to HIV, lowering tryptophan, or indeed uptake of INH, which interferes with the niacin synthesis. This is exemplified in the diagram on the right. Okay, so the investigation from Malawi, the preliminary findings are that the INH-associated pellagra appears to be rare in that they only discovered it in 1% of the patients who are on IPT. And then most persons with pellagra had mild disease. This pellagra that they were seeing in Malawi, they could easily treat it by way of stopping the INH and give the patients a multiplex of B vitamins for about 30 days. Generally, the clinicians could not, or rather misidentified pellagra like rashes, and these cases are now being reported from Zimbabwe. Is it possible, therefore, that we are seeing the same picture in Zambia? Okay. Now, for phase 2 results, where we did a bit of demographics and descriptive statistics, we received information on 37 patients, but those who were classified as HIV positive were 35, and the age was around 37, ranging from 17 to 58. Most of the patients that we received in terms of the information we got was from, the patients were female, 84%, and Lusaka gave us about 70% in terms of where the patients were coming from, and then the others as outlined. In terms of the medication ART regime, 14% or 5 were taking TLD, and TLE was in 86% of the patients that we saw. And then 26 of the patients that we saw were on INH, and only 21% or 6 of the patients were underweight. Now, in terms of the rash characteristics, there were so many that we're looking at, but in summary, the sun-exposed areas, those who reported that they had the rash in sun-exposed areas were about 69%, and those with hyperpigmented lesions were around 71%. Those with both sun-exposed and hyperpigmented rash were somewhere around 57%. So in summary, we're saying that the cases reported are likely a representation of a mix of diagnosis among people who are prone to skin conditions. Okay, and pellagra was the common condition being reported. Given the high incidence of HIV and TB in Zambia, pellagra and pellagra-like states always need to be considered. Continued surveillance for the rashes among people living with HIV will be critical to better understand this issue in Zambia. And the ECHO session likely helped raise awareness of rashes among people living with HIV, which is commendable. And this is a form of enhancing surveillance. And lastly, clinicians are requesting assistance and guidance for managing rashes in people living with HIV. As a way forward, we shall continue to investigate the rashes among people living with HIV, and we're requesting that you please fill in the case form, because we've provided the link on the next slide. And as much as possible, if you could get clearer slides and photos of the patients that you're seeing, that would go a long way. It will help. And then we need to have a discussion of the clinical recommendations for rashes among people living with HIV. For example, do not stop ART unless life-threatening condition. Is that the guidance? Or indeed, if suspecting pellagra, we have to withhold the INH and supplement with nicotinamide or vitamin B complex. And then an additional investigation of the pellagra among people living with HIV may have to be undertaken as well. Okay, so that's the form that we are using to collect some patient-level data, and that is the link that is provided. I'm sure it will be shared further with the help of this platform. Yeah, in discussing, you take it up from here. Okay, thank you very much.
So we've got several discussion points, but because of the breakaway sessions that we have, some of the questions starting from number 3 actually can be discussed from the breakaway sessions. So I will allow 1 or 2 contributions on the first 2. So the first one is, what type of rashes are you observing among people living with HIV? So please, you can indicate by show of hand using the platform so that you contribute to that question. Anyone who can go first? What type of rashes are we observing? That is just generally among people who are living with HIV. Any hand? Okay, now we can start volunteering people. Chipata, are you observing any type of rashes among people living with HIV? Chipata Central.
Hello. Hello, good
Good afternoon, we can hear you.
Can you hear me?
Yes, we can.
Yes. So at Chipata Centro, we are observing some rashes. I think it's a type of photoallergic.
Photoallergic reactions.
Yes.
Okay, thank you very much. What about Namseche? Are you seeing any rashes in people living with HIV?
Currently, we haven't yet noticed anything, any kind of rash associated with that. And the type of rash that we're seeing is photoallergic as well.
Thank you very much. Arthur Davison.
No, currently we have not. Considering that here, anyway, we are dealing with pediatrics, so we have not noticed anything.
So children are not presenting.
Try to be on the lookout.
Okay. Now,
No.
All right, thank you very much. Can we discuss, do we think there's been an increase in rashes among people living with HIV recently? Kanyama, what's your thought on that? Kanyama level 1.
Okay, so for Kanyama level 1, we've not really seen any increase on the rashes, though we have some kind of photoallergic reactions with some clients, but there are few and minimal clients that we are managing. So we don't have.
Okay, so there is interest. Thank you very much. What about Livingston? I think you have your hand up.
Good afternoon.
Good afternoon.
Yes, I think as for Livingston, I think we had about 3 cases of clients presenting with Verrebra, and the most commonest one in terms of rashes we're seeing are flat warts, that is Verruca plana. Those are the ones that we have.
Okay, thank you very much. So now, after the didactic presentation by the doc, we'll now go back to our poll questions. We see how much of information we have retained. So which of the following is associated with side effect of dolutegravir? A, metallic state, B, depression, C, hyperglycemia, D, rash. You have to wait until we relaunch the poll. So we can give it a shot. We have got 30 seconds. A few more seconds, only half of us have polled. Have we become more confused?
You can come here. No, that's come.
Rash is a side effect of personality.
The second poll question is, rash is a side effect of isoniazid therapy. Is it true or false? Rash is a side effect of isoniazid. Is it true or false?
by the host.
Which of the following depicts the classic rash associated with pellagra? Okay, this is encouraging. Okay, we go to the last one. And the last question is, which of the following is the classic symptom of pellagra? A, difficult breathing, B, depression, C, dyspepsia, D, diarrhea. All right, so we'll go through and with our experts, I think here, Dr. The first question I think we have seen the way forward. Talking about the side effects of dolutegravir, I think the majority now have gone for hyperglycemia. And previously that was only 6%. So there's definitely a change. What really is the answer here?
The answer is C, hyperglycemia. It's one of the side effects that you usually see when you put people on dolutegravir, including changes or abnormalities in the LFTs.
Okay. Any comments on the other options? I think we have got about 15% going for rash.
Okay. We said commonly associated. However, rash still is a symptom, or rather a side effect that you would have when you are put on DTG, as we indicated in terms of the hypersensitivity that you see. In 1%, you still get it. But we were trying to highlight that maybe the common one you see could be hyperglycemia.
Okay, so that's how we voted. I think there was an improvement because the option C was only voted by 6. We can go to the second, isoniazid. Ratika,
yeah.
Comment on the correct answer here.
The correct answer is A. Isoniazid can cause a rash, which is true.
All right, so thank you very much. And I think a lot of people have gone for the same. Although these before and after, the choices have remained the same. So I think it would be interesting to know why people thought it was false. If at all you're in the network, please drop us a comment in the chat box why you thought the answer is false, because the numbers are still the same. Yeah, okay. People have still voted the same way. And then this third question, I think it's about the classic rash associated with pellagra. So, which just a comment on each of the rashes that we are seeing, Dr. Chika.
Well, would you go to the presentation?
Okay.
Where the rashes are. So, yeah. So most of the rashes that we're seeing in terms of the classic presentation of pellagra is in the photo, rather sun-exposed areas. And more often you have the hands, the feet, and also around the neck. And usually, you can go to the other answers.
So this?
Yeah, these ones. These are the other rashes, which are basically like the pemphigus vulgaris. That is how it presents. And the other one, the mobiliform drug reaction, I think this is a common drug reaction that you tend to see. And yeah, so this was actually with the help of our dermatologist who indicated that the classic one will have, what do you call this? The Coro's necklace? Casso's necklace. Yes. So we're just trying to depict that there.
All right. So thank you very much. And I think the majority went for C, which is actually what we have seen. The last poll question is, which of the following is the classic symptom of pellagra? So again, a comment on the choices.
Yeah.
I think we have seen almost 90% going for diarrhea.
So basically the 4 Ds that we talked about included the dermatitis, which is a rash, the diarrhea, and the dementia as well. So here we're just trying to see if people could pick up the 4 Ds that go with pellagra.
All right. So thank you very much. I will allow 1 or 2 questions before we go into the case discussion and presentation. So if you have got any question, I know that there was a comment from Chikankata which said they have seen a rise in photosensitive rash at Chikankata, but they are doubting, maybe they are saying it could be due to IPT. Any comment on that, Dr. Hines? And I think another one in Chilanga, I think they have seen an upsurge of rashes in patients on INH.
Thank you. I think this is an interesting discussion, and we're talking about a population that tends to develop skin conditions, and so it's likely that different types of rashes are being observed. But as we've seen here from the case presentation, it seems like there are some types of rashes that may be happening more commonly. At this time, we're still trying to sort out exactly what's going on. And so I think it's important as clinicians are seeing patients living with HIV who have rashes to try to help us sort this out by submitting the rash case report forms, as was shared by Dr. Chika. INH is known to cause pellagra, and so that seems like that may be going on, but we think that there is a mix of diagnoses going on.
All right, thank you very much. Dr. Wakas, you have raised up your hand. Please go ahead and ask a question or a contribution. Dr.
Hello?
Yes,
can you hear me?
Yes, we can.
Okay, mine is just a contribution, on the rashes of pellagra. It is also very common among the alcoholics. So the patients who are dependent on alcohol, we get also a lot of patients with HIV who are dependent on alcohol as well. So we should keep in mind that that's also one of the cause of the rashes of pellagra.
All right, thank you very much. So Dr. Wakas is a psychiatrist, and I'm sure sees a lot of patients who are alcohol dependent. Any other question or contribution on what has been presented today on the topic today? Okay, so we'll then straight away move to the case presentation, and it's coming from Senanga General Hospital, and it will be presented by Movita Skufele, who is the pharmacy technologist there. So Movita and team, please take it up.
Good afternoon.
Good afternoon.
Thank you, Doc.
All right, we can hear you now. Thank you. Go ahead.
Yeah, my name is again, I'm Vikas Kufele from Senanga General Hospital. I'm a pharmacy technologist. We'll be presenting on a case of dolutegravir, an adverse drug reaction that we've noticed. Yeah, the slides, please. Hello, Doc. The slides, please.
A minute, Movita. The screen is sharing is paused. Why is it paused? Anything I haven't done? Go ahead now.
All right, thank you. Yeah, the history. We had a case on Miss LL, a female aged 49 years, married with 5 children, and was diagnosed HIV positive on the 14th of November 2016. And Miss LL was initiated on 21st November 2016, and then was put on the first regime, that is tenofovir, lamivudine, and efavirenz 600. The other drug history was cotrimoxazole, OD, and isoniazid 300 OD with B6, vitamin B6, 25 milligram OD. And then on the 19th December 2019, Ms. LL presented to the art clinic with skin discoloration lesions on the neck, arm, legs since June the same year. And she also complained of heart palpitations sometimes. And on the parameters we did, on the day she came, we did the height, which was 75 centimeters, 175 centimeters. The weight was 71 kg. And the BMI was 0.3. The temperature was at 6.9. The pulse was 86. And the respiratory rate was 20. And the BP was 112/76. I can't see the other side, Doc. Okay, thank you. And the past medical history, Miss LL is a non-hypertensive patient. And on the 15th of November 2016, she presented with oral thrush, which was treated. And the patient last had IPT in 2016. And there was no history of traditional medicine or only ARVs. And the clinical timeline and the lab results, the date started, and also the date the client stopped. On the 21st of November 2016, the client was put on tenofovir, lamivudine, and efavirenz. That's a tripler with 600 milligram of efavirenz. And then on the 21st of November 2016, they also included cotrimoxazole, isoniazid, vitamin B6 for the prophylaxis of tuberculosis. And then on the 8th of January 2017, the client was stopped on IPT and CTX. And then on the 4th January 2019, the client was transitioned to Avonza, the tenofovir, lamivudine, and efavirenz 400. They reduced the strength of efavirenz from 600 to 400. And then on the 21st of June 2019, the client was transitioned to DTG 50 milligram base regime. And then on the 19th of December 2019, the client was stopped on the Avonza, that's TLE. I mean, the client was put on the TLE again because of the reaction that he had on the DTG. And then the tests that were done on the 16th of November 2016, the CD4 count was done and came out as 264 cells per mil. And then the action was baseline. And then on the 4th January 2018, the CD4 count was done again. It was 458 cells per mil. And on the 7th of February 2018, viral was done. It was 237 copies per mil. And on 7th February 2018, HB was done and it was 11.4. On the 24th of August 2018, the viral load was undetectable. Same on the 15th, it was also undetectable. And then the patient was advised to continue on the drug regime that was put on. That was on 15th of September 2019. Next slide, please. And then our questions are, what is the likely cause of the discoloration? And if the discoloration is due to the drug, can one rechallenge the drug? And why is it affecting females? Because in our case here at Senanga General Hospital RT Clinic, we've captured about 6 clients presenting the same effects, and all of them are females. So we'd like to know why is only females of having this effect, and what is the likely treatment to this condition. Thank you. We are not.
You can join the break session.
So I join.
.164 cells. She was studied on a tripler. Sorry. How do I start?
Just join the room.
Sorry?
Just join.
It was you. Yeah. All right. Okay. So I will start. So we are discussing a case of a 49-year-old woman who was diagnosed with HIV in 2016. She was started on ART in the same month in November 2016, and the baseline CD4 was 264. She was started on a tripla, which she took. And at the same time, I think she was also started on prophylaxis for PCP with Septrin, isoniazid 300 milligrams for TB prevention, and vitamin B6 25 milligrams prevention of isoniazid side effect. She took these drugs up to 2017, 8th January, that's when the prophylaxis was stopped.
Sorry, I don't know if there's someone leading spearheading the group who are asking to say, is there someone who has noted down the question to go through so that we can at least discuss?
The question again. They've removed some of the questions.
Hello. Hello, Kanyama. Hello, Kanyama.
Kanyama. That's Kanyama.
Oh.
What's the answer?
Hello. I usually assign the chairs. Senanga General, can you hear me? Hello?
We can hear you.
Kindly help us with the questions once more.
Okay. So the first question goes like, what is the likely cause of discoloration? Number one, what is the likely cause of the discoloration? And if it was due to DPG, what can the drug be recharged? That's question one. Question two, why is it only affecting females? Because that's the case we're having here. Only females have been infected. So why is it only affecting females? And the last one is, what's the likely treatment? I hope you are clear.
Do you have any images of the same patient?
Yes, we have. We have.
Okay, you can kindly share to the group.
But unfortunately, I don't have them right now with me. On the computer that I'm using, I don't have them right.
Oh, okay. Okay. Thank you.
Sure.
So this is Dr. Hines speaking from UTH. Does anybody venture to give a thought on the cause of the discoloration?
Anyone?
What is the like? Presentation. Is there any way they images?
Hello, this is Choma. Do we have anyone who is taking the lead now?
Well, the doctor just stepped out.
So we should wait.
No, I think we can continue discussing. So he was asking anyone to contribute on the likely cause of the discoloration.
Okay.
I've just joined. I don't know. I've just been taken back here. I don't know. I wasn't here. It's like I'm lost.
So where is that information? So we are.
Hello.
Hello.
Sorry about that.
I don't know. I've just joined the group. I was in the other group. I don't know how I found myself here. But we are answering a question on the first one. What could be the likely cause of the rash? I don't know if that's what was answered or not.
It's not yet answered. Would like to get more information from Sinanga. Did you find out about any drug allergies? Because from the presentation, we could tell that the rash started in June, a few months before the woman was started on ART. So there's a big doubt if the rash was associated with ART.
Yeah.
Okay. The drug, according to the file of the client, the client had started the rash after she was put on TLD based regime, and the patient refused of any use of any traditional medicine and was not on any other drug except the hypertensive drugs. Yes. And in addition, the client was not on IPT.
Would you mind sharing the antihypertensives that the client was on? Maybe we are considering the drug-to-drug interaction.
Okay, unfortunately, the client, in the setup of Sinanga, a lot of people stay in the plains and stay in the plains, stays very far. We were unable to track her to check what kind of drug she takes for hypertension. In her files, they are not indicated. And she's unreachable on mobile.
So we have not yet answered the first question. Anyone from the group, what could be the likely cause of the rash? Having that basic information about the patient.
Hello.
It would be better if we happen to see the image. Some of us we just joined recently, so we haven't really seen the image of the same that you're discussing.
I don't know if it's possible to show the image at this point with the technology, but it showed a hyperpigmented rash distributed in a sun-exposed area.
Yeah, this is Choma. I think like our dear colleagues, I think will benefit more if we saw the picture. I don't know if Sinanga is in a position to show us just a picture, even just right now on the phone, if it's possible to do so. Because it would be difficult for us to, yeah, to answer.
Hello, the network is too quiet. We have got very few minutes remaining.
We are too quiet. Yes, Francis, why
Yes, Dr. Chan.
Was the rash associated with isoniazid?
So isoniazid was...
For this patient, yes, it was associated with isoniazid.
Isoniazid was...
I mean, the whole...
Dr. Chanda, your network
I get it.
Your network is breaking. But I wanted to say that isoniazid was stopped in January 2017.
Oh, I see. But then he didn't mention about the other cases. And then the other cases were not told whether they are on INH or not.
So it says the 3 cases that they have presented, I think this is a second. Both of them were not on isoniazid. And both of them were females.
All right.
So I think that's why they're asking, why are they seeing just these rashes in females? Any explanation?
Yeah, which part of it?
Yes. Yeah, the
Sorry?
The pixel we are using is a bit limited.
Oh yeah. Yeah, actually on this phone, it's small, so you can't see them clearly. That's why I was saying maybe Chipeta can view the pictures again. Thank you very much, Joe. So these are the pictures, the legs, on the arms, and in the neck, around the neck. Choma, general, are we now clear?
Yes, we are clear. We are analyzing them very well. Thank you. They are very clear now.
Thank you very much.
I think we can now go back to the questions.
So, I think that maybe the case is trying to suggest there's a temporal association between the start of dolutegravir and the development of rash. I don't know that there's enough clinical information to actually say what the cause of the discoloration is. Just because things are related temporally doesn't mean that they're causal. So I think that the answer to the question is it's unclear. I don't know what the cause of the discoloration is. That being said, it's not a rash that's been associated with dolutegravir. Dolutegravir is not classically associated with rash. terms of re-challenging the patient, my opinion is that PRT is life-saving. Dolutegravir is a superior drug to efavirenz in terms of viral suppression, adverse side effects, and development of drug resistance. So unless someone is experiencing a life-threatening or potentially life-threatening reaction, we challenge it, right? Because you have to weigh the risks and benefits. In this patient, it's possible that the rash is due to the dolutegravir, but I don't know that we know that for sure. But one way to find out would be to follow the patient to see if the rash resolved after changing the medication, and then potentially re-challenging with dolutegravir. Stress the point that if a patient is experiencing a potentially life-threatening reaction, you have to stop potential. If not, you have some ability to try to find out what's going on, especially in a situation like this where it's not exactly clear. So just to stress what we mean by life-threatening reactions, they're potentially were manifested skin conditions. The classic cause would be Stevens-Johnson syndrome, which presents with skin sloughing, so the skin actually detaching from the layers below. Sometimes you see it just in the mouth, but it can also involve the entire body. If you see that, it's an emergency, and the patient needs to go to the emergency department to be treated because it can be life-threatening. Other types of adverse drug reactions that are life-threatening would be hypersensitivity, specifically an IgE-mediated hypersensitivity, where someone presents with anaphylaxis. In that situation, the person might have swelling of their oral cavity and difficulty breathing. Those people should be administered epinephrine immediately, because that's life-saving, and then also transferred to the medical ward for management. But I don't think that that's what's going on in this case. So in my opinion, I think that following the patient, seeing what happens with the rash after the drug change has been made, since she already has been switched back to TLE, is fine. But I think that re-challenging with dolutegravir would be okay. Over. Did the people online hear any of that? Yeah, I think we can get them to know. Technology has failed us again. You guys have any questions?
I think that's the last question.
Why is it affecting only females? Okay, so
what is the life restriction?
Okay, so no, going back to question 2, why is it affecting females? I mean, this is a single case report.
Okay, thank you very much and welcome back. So I will ask group 2, where Dr. Kozia is, to please kickstart the discussions and tell us what they discussed. Dr. Kozia. Is Dr. Bill? Oh, okay. Dr. Bill? Dr. Kamala?
Hello, Doc.
Yes, we'll start with your group. Could you tell us what you discussed? Share with us what we discussed.
I was taken from one group
to another, I didn't really stay in one group. That's what actually my reaction. I want to tell. I didn't stay in one group.
So
I was sent in your group first. From there, I was sent another group at UTH Hub there. And I didn't get anything from that group. It was just one person talking, and we were just talking like the voice was breaking.
Okay. So who was in the group 2 UTH Hub? Dr. Jones, Dr. Hines.
Oh, yes,
Dr.
we're here.
Hines.
Sorry, we were unmuted. We were on mute.
Okay, yeah, please go ahead. You can tell us what that group discussed.
Well, I'm sorry to say that I think the majority of the time was taken up by technology difficulty. But I think the discussion was relatively limited, but we did discuss how there's potentially a time association between onset of the rash and starting dolutegravir, but that it's difficult to attribute the rash to dolutegravir, and that probably following the patient to see what happens with the rash after switching her back to TLE would potentially help establish the cause of the rash being dolutegravir or not. But that in general, unless the patient is experiencing signs and symptoms of a life-threatening reaction, changing ART regimens may be premature, because dolutegravir is a superior medicine to efavirenz. And so in this case, it may have been okay to leave her on dolutegravir and try to manage the rash. I think that was probably most of what we spoke about.
Okay, so could this patient be changed back?
Sorry.
Could the patient be changed back to DTG?
I would say yes. The rash doesn't appear to be life-threatening, and so I think it would be okay to challenge her again.
Okay, thanks. What about the other two questions? Did you manage to discuss them?
Only very briefly.
Sorry, why females and what treatment options?
Yeah, so why females is also a difficult question to answer, because I think that there's probably, amongst the cases that Dr. Chika was presenting, there's probably a mix of diagnoses. It's not a single unifying diagnosis. So to see a female predominance is, and attribute that to a single cause, I think is difficult to say. One hypothesis that was suggested, though, is that females tend to be health-seeking over men, and so you may have a selective bias amongst the population, and that you're seeing more females because females are more likely to seek care. But another idea, I mean, is that if we're talking specifically about micronutrient deficiency in pellagra, women may be more likely to experience malnutrition than men are too. So you may see a female predominance there. And then in terms of treatment, so we already talked about how it's probably okay to leave this patient on ART as long as they're not experiencing symptoms of a life-threatening condition like Stevens-Johnson syndrome or anaphylaxis. But one approach in a patient like this where the diagnosis is not clear is you could try a hydrocortisone cream twice a day for 2 to 3 weeks and see if there's an improvement in the symptoms.
Okay, thank you very much. Dr. Zico. Dr. Zico from AIDC.
Okay, good afternoon, Dr. Mpeta.
Good afternoon.
So this is David standing in for Dr. Zico. He has a commitment. Otherwise, for the first one, what the likely cause of the escalation is in this case, we thought it is drug related, and this being DTG. And concerning rechallenging, unless there are no any other options, rechallenging is very much discouraged. We think switch to the option, and in this case, the right thing was done. You switch to CLE, which is okay. And then concerning the second question, why is it mainly affecting females? Of course, okay. Of course, concerning why it's affecting females mainly, Dr. Sibile, what do you have to say?
So Dr. Mpeta, so we thought this was just, it wasn't pellagra, no discussion, it wasn't pellagra, it's just photosensitive rash due to DTG probably, we think. And we think because it's an immune mediated kind of disease, we thought it might not be wise to re-challenge in the view that we do have options. Then why these are common in females? Obviously because they are immunologically mediated, just like any other autoimmune diseases, you know, and we gave a caution to everybody that photosensitive rash is not equal to pellagra. There are a lot of causes of photosensitivity, you know, SLE, you know, whatever, there's so many of them. So when you find a photosensitive rash, you don't say this is pellagra. And there are no risks or in the history of this patient why they should be having pellagra at this point. The likely treatment is switch the drug. Stop the suspected offending drug, which is and probably we'll make other comments later.
And of course, however, we would like to know when the DTG-based regimen was started, because that history is always very important, so that you know and have a clear relation of the rash to the drug, which was not given in this case.
It was started in June, and the patient presented in December. So that's like 6 months apart.
Okay. All right, thanks.
Okay, thanks. I think the last one was about treatment, is it? Did you discuss that?
Offending drug, I think that is the basic thing that you need to do, and hoping, of course, with the rash will disappear. And if there are any other things that you may need to give, I think Doc had explained in his didactic presentation, you may think of the B6 or the nicotinamide and all, just to try and lessen the problem there. But do not forget to remove the offending drug.
Okay, thank you very much. In group one, we also thought that there was a bit of a dissociation between the drug, DTG. So we thought maybe it could not have been due to DTG. And we thought probably this was a micronutrition deficiency, and then HIV, diet, females of childbearing age are prone to developing micronutrient deficiencies. And then the reason why they are being seen in women, apart from these other issues, is because women are likely going to come to the health centers than men, and hence there's that kind of bias in seeing more women. We thought nutritional support and supplementation in this patient will definitely be important and will help. The bonus questions, we also discussed about if there's been any increase in the rashes. I think different contributions, but generally these rashes are absent in children. And again, it will help us now think about if we are attributing it to nutrition, and then children who are infected with HIV and who are even more prone to malnutrition, why aren't we seeing this kind of rashes? So it's still kind of, very confusing when it comes to these questions. Now, has there been any upsurge in IPT take-up? Yes, we said there has been. And how can we prevent pellagra by supplementation with B-complex vitamins? And I think that was the basis of our discussion. I will allow a few contributions from Alzira. Alzira, please go ahead. I hope I got that pronunciation correct. Auzira. Then a contribution from Mazabuka, they are saying that the reactions are being seen in sun-exposed, and then they feel females actually seem to be underdressed compared to men who dress everywhere. So you find that the rash is not seen. So that's a contribution from Mazabuka. Namseche think the time frame for DTG reaction, what is the time frame for DTG reaction in clients who come 3 months after transitioning to DTG? Should we say that is due to drug reaction, and is it safe to transition the patient back to TLE? So they are basically asking, what's the time frame for us to associate a drug reaction to a patient who has been on ART? Any thoughts on that, experts from AIDC, Dr. Duncan, and any other people might want to comment on the time frame for association?
Yeah. Hello, Dr. Pet, can you get me?
Yes, we can hear you, Dr. Sivile.
Yeah, yeah. So I think I was just discussing in our room.
Sorry, I'm muted. We can't get you, Dr. Sivile. We have lost sound.
Yeah, I think we've been muted.
Okay, please kindly repeat what you said. I think you were off.
Yes. It's important to make a diagnosis, a clinical diagnosis of what that side effect is, from the history and everything. We know what pellagra is. Pellagra has, it's a syndrome. There need to be some CNS issues, confusion, dementia, or whatever, how it presents. There can be some diarrhea, some peripheral neuropathy, and the like, which are missing or maybe not reported in this patient. So, maybe the case needs to be revisited to get more information for us to give advice, but right now, it's difficult to pin this on nutrition without a clinical or historic, social supportive, story. But to answer the question, when do these side effects occur? So if it's a hypersensitivity reaction, it will start probably around day 4, day 5, somewhere there. But if it's just, something that is like lupus related, it's a photosensitivity. Sometimes it will take time, 2 months, 6 weeks, somewhere there. That 12 weeks is within the time period. This can as well be a lupus related. This is hypersensitivity. And like we said, hypersensitivity is not equal to pellagra. There are a lot of other things. And maybe that's why this team felt that. Maybe that's why, these hypersensitivity reactions are slightly more common in female because they are immunologically mediated. And this is in parallel in cases we've discussed on those which are reported under INH bracket, where people thought this is pellagra, this is that. But when you examine the case, they look to be more hypersensitivity related cases and nothing to do with nutrition. Not to say that pellagra doesn't happen, it does happen. There are a few cases which are genuine cases of that, but you need a clinical diagnosis, and Dr. Chika did give us what that clinical diagnosis or syndrome is. The 3 Ds, and probably some later to progress into the 4th D.
Okay, thank you very much, Dr. Sivile. I will allow one last contribution from Senanga HNP students. And I think this is where Ambita is. Yes, please go ahead.
Thank you, Doc. Just a follow-up on the previous presentation, where the doc, although I didn't get his name clearly. Yes, the only thing that we are behind with was on the hypertensive, the core drugs that the patient is taking, because the patient didn't mention of the antihypertensives that she takes because of the terrain in the area of Sinyange, because she lives in the plains and she's unreachable and mobile. But otherwise, according to the information, according to the file, the client, once in between, not clear with the date, but she came, presented the same symptoms, but we had to give the patient for a month, and then when he came, when she came, she presented with again the same complaint with, she said sometimes she experiences heart palpitations, which could come and clear after some time. Yeah, so just an addition on the information of the client. Thank you.
All right, so thank you very much. And I think from today's, some of the takeaway points is that remember that rashes can be due to anything. It could be pellagra, it could be photosensitive drug reaction, and it could be any other reaction. And I think we understand the limitation in which we have. So the takeaway points is that please, if you get any skin reactions, kindly report. We have circulated the forms, online forms, and if you can use the platform for 7070 and see how you can be assisted. And then please get permission from the patient and get good quality photos with, of course, the guidance from the experts so that we can see how we can assist these patients together and bring on dermatologists so that we can improve the care for our patients and see that unnecessary switches back and forth between TLE and TLD are avoided. And I hope that Mubita and team, please, you have learned one or two things. Now, because of the time, we have gone beyond 16.
Dr. Mpeta.
Definitely be expecting a case. So please, if you have got a case, kindly make sure that it gets to us and then we see which one can be presented. Thank you very much. I don't know if there's any other announcement.
Dr. Mpeta, could you have a programmatic announcement?
Please, Dr. Sivile, go ahead.
Yes, so I think this is to answer the question that was posed. Are these cases more or getting worse? As a program, we can't answer that question now. I think there are fears around. People say there are more cases than usual. You know, if a facility sees 3 patients who have these side effects, the question is 3 patients from how many? We need that denominator, you know, so for us to say these are more or new, whether we need to act or maybe it's the quality of drugs and the like. So to answer that question, we've come up with the active pharmacovigilance or the cohort event monitoring, you know, mechanism as a program. So this, you find it in the ART guidelines. There's a form there which you need to fill via SmartCare. So you will recruit patients, following them up for maybe a year or so, where you need at each review, side effects will be assessed for, so that at the end of the day, we can answer these very important questions. You know, it's 3 rashes out of 100. It's 3 rashes out of 1,000 and the like. So please watch out for this active pharmacovigilance or cohort event monitoring mechanism. We'll talk more about it as we move on, but it's not replacing the passive pharmacovigilance forms that are available. Please fill in those forms, but we want you to start recruiting patients. We'll give the protocol and the directives how this is supposed to be done in due course, but it will be best via SmartCare. Thank you very much.
Thank you very much. I think Dr. Sivile has just emphasized the need for us to report using pharmacovigilance forms. And then we've been informed that it has now been embedded in SmartCare. And I know that the majority of us are using SmartCare. So please, let's be smart and ensure that we report all the side effects that we are seeing, including skin rashes, so that we can improve the program. From all of us in the hub, till next week, goodbye.
Thank you. Well done. Well done.
interesting. Try 8 minutes.